going to take two small topics today. We'll defer our critical appraisal after the mic is over. So the first one is going on about AI in medicine. So today is going to be a little bit about ethics of AI in medicine. Just a short 10 minutes on ethics of AI. Okay. So ethics of AI. This is a document by National Academy of Medicine. It's like a big body in US, all top scientists from various medicine, engineering, physics, chemistry. They all come together and they form this very prestigious organization. Every month they do some sort of bulletins and guidelines and documents. So this one is a one from I think 2024, AI Code of Conduct. So I'll just give three quotations from that. So the first quotation is, people are scared of dying. They're scared of losing their mom. They're scared of not being able to parent and walk their child down the aisle. How can we start using the power of these AI tools? Not through the lens of fear and reluctance, but to create a culture change from doctor knows best or patient knows best to person powered by AI knows best. So I think people got very angry when they said AI is going to replace doctor or patient. So now it's instead of artificial intelligence, it's augmented intelligence. Patient could be augmented, doctor could be augmented. So instead of saying doctor augmented intelligence, it is person augmented intelligence. So that's the first quotation by them. The second one is Universal Declaration of Human Rights includes right to enjoy scientific advancement. This has been a dormant right, and we have failed to operationalize it and to promote it. So they're saying AI could be a way of everybody, poor people also enjoying the benefits of science. The last comment from that document is historically, technologically advancement, healthcare disparity gaps are widening. So the rich get better treatment, poor get worse treatment. AI runs the same risk, but it's an opportunity to avoid further exacerbating this among populations. So we have to introduce culturally competent care and understand determinants that affect the outcome. So we will be aware that AI can do harm if poor people are culturally, or some cultures may not get the benefit of AI. So this is a little bit about AI. The second thing is, if we develop an AI, like Dr. Vignesh developed this AI model, we can try it out and see how good it is in a website, online platform, how good is our AI model. So this Mayo Clinic has got a platform called Validate. So you can upload your model onto that, and it will give you how good your AI platform is. So this somebody has uploaded different number of models, and it will give you sensitivity, positive predictive value, specificity, negative predictive value, and it will tell you whether the population demographics are biased towards one group or not group. So that's a real advantage. So if you plan to do AI, you can try out this Validate thing. The second thing it will give you is, it will give you some scores. It will tell you the classification. Was the model done well? Model done badly? If you remember ROC curves, it will tell you that how good the model is. First in the build set, that is when you are deriving the model, you've done that before. So when you're deriving the model, you do it on one data set, and then you validate it on a subsequent data set. Usually the performance will drop when you do it on the subsequent set. What you derive it is obviously good because you're over fitting that. But when you do it on a blindly on a new set of data, it doesn't do so well. But all this nice software does it for you. Philips is one of the large medical device manufacturers. So they also have got some AI principles on their website. One is well-being. There should be good oversight. The AI model should be robust. We should give fairness to people and transparency about the AI model. So I'd say even the pharmaceutical industry or device industry has got all these kind of things. So Philips suggested these principles from their net. This is Google. And Google is doing so many health related things. This ophthalmoscopy, Google has got their own version of it. So Google has said AI should be socially beneficial. We should not reinforce biases. It should be safe. It should be accountable, privacy, highest scientific standards. So even Google is saying these things. But I thought I'll say what they say it should not do, AI in health. We will not pursue those technologies which may cause harm to patients. You can even find out which patient may not benefit and avoid those patients at all. You can do some bad things also. So technologies whose implementation will cause injury to people. Then technologies which are used for surveillance of people, those we won't do. International law and human rights which contravenes those we won't do. So I'm just saying that even Google, all these companies are very aware of AI and ethics. Okay. So they're saying that we have to constantly be aware as AI becomes more and more everywhere. We have to be more and more evolving in our ethical practices or discussion about AI and ethics and health. Just to give some examples of AI, some RCTs. This is AI in limb physiotherapy. The person has a stroke, then you put a AI model on one hand, give them a virtual tool, and then try to make them do some physio using that tool. So this is one artificial intelligence rehabilitation in China. It's come out well. The second one is in Parkinson's people to encourage them to make them a little bit happy. A chatbot for a Parkinson's people can it make them happy? It will seem to work. The third one I just want to tell you is this one transcranial Doppler for neuroendocrine people and whether the AI can help in transcranial Doppler. So this is important. This paper was actually withdrawn for being fraud. So because AI has got this, everybody if you put AI people and publish it left, right, and center, and the journal editors may not be aware of like what is really going on in the publishing. This paper afterwards somebody said, hey, much of this data doesn't look original, and then they found it was fraud, and the paper was actually withdrawn. So the scope of there was some discrepancy in scope in the description of the research, the data not being available, citations, meaningless content. So even the content was generated by AI. So some fancy sounding sentences. So that's something to be careful of. So where all can AI help us in randomized control studies? It can help you in study design, sample size, selecting your population, and looking at potential biases. Already we are using SPSS for randomization or other software. AI can help you do that. We are doing participant allocation through, let's say, opaque seed envelopes. AI can help you to do that. And it can help reduce selection bias, so make sure that baseline is equal. Data collection. Increasingly, people are having the data on the smartphone or the smartwatch, and this data is directly going to an AI, and the data is being collected, or any other wearable devices or electronic devices. So, data collection using AI has increasingly become used all over the world. Data analysis. Well, we are all doing data analysis, but AI can do the. If you just tell the AI, it can do the entire analysis for you, modeling, machine learning, then large amounts of data, so large amounts of tables, and it can give beautiful figures which are easily understandable. That science is data visualization. It can also help engage patients. So the patient, you want to take part in the trial, the AI can tell the patient what's the benefit of taking part. Patient retention, okay, this patient is unhappy about something, the AI can help you in that. And adherence to protocol, the AI may give you reminders, it may say do this, do that. So patients also it can help. Now, site selection, let's say you're doing a multi-center study, and you say, shall I recruit this particular site? The AI can tell you, okay, that site has done some previous trials, it can analyze and give you that site is doing well, or that site previously had some problems with recruitment and they don't do the monitoring correctly. Then the management, like the financial management in the site, administrative burden, instead of people filling up numerous reports in every site, the AI can do a comprehensive report, it has everything. It can generate reports and somebody has to verify. Problem is that somebody should not say automatically the reports and I don't know about it. But it reduces so much amount. Instead of having 100 staff, you can have one AI and one staff. Risks in the AI. It can help you look at this. Okay, side effects are suddenly a couple of mortality more in the same multi-center trial, 3, 4 people die in that center. So you guys need to be careful in this center. Or some side effect, an unexpected side effect occurred somewhere else. Or somebody sued this clinical trial with some other site for this issue. So it can tell you about those risks. And it can do it in real time. Other you do the whole trial and after the trial, oh man, we made so many mistakes. If only we knew this halfway through, we could have changed our way. So in real time, we can help you do this. That's called risk mitigation. So we can reduce, we not avoid all risk, but we can mitigate the amount of risk. So now the next question, I'll speak about that a little while. Then suppose we have patients and we can say, okay, this patient is unlikely to benefit from this clinical trial. Usually we take patients, we randomize them. The AI can even say that this person is unlikely to respond to this drug. So we may not even need to recruit such a guy. So it may seem a bit like match fixing, but it can help you in that. Finally, it can generate the whole RCT report. You collect data, it analyzes the data, and writes the whole report for you. I mean, not the whole thing, but you can look at the trial status, patient safety, efficacy outcomes. Now, all clinical trials have to have GCP, that's good clinical practice compliance. And you give a certification in Western countries that my trial complied with that. This AI can help you to make sure that it's all GCP compliant. And there's a healthcare HIPAA association. We can make sure that it will help you to see compliance to that. So the last thing for today, this talk is selecting patients for RCTs. Okay. So if you need to screen 10,000 patients for some inclusion, AI can screen those 10,000 patients instead of you screening it. Yes. AI can help you screen the 10,000 patients. So in that, it will tell you which patients are likely to take part or may not take part based on what it knows. So it can lower your sample sizes. So you may say that these confounding factors I don't want in my patient. So the AI will select patients without that potential confounders or misclassification. I want only people on previous MI. Sometimes we have screen and some MI is for no MI given history may pick up, but this will be able to classify fully those who had MI or not. Suppose you have a complex inclusion criteria. Patients must have this history, this physical, this laboratory, this genomics, and this proteomics. The AI can easily do all that together instead of one person sitting and screening each patient for all of that. The patient can do increasingly clinical trials in oncology, cardiology, infection disease, and complex inclusion criteria. So this can easily help you screen people with those kind of criteria. So now there's an example where Academy of Ophthalmology, intelligent research inside data in RCT, they used AI to help them to collect patients for their ophthalmology RCT. So one of the problems is this AI. Sometimes when we have this inclusion exclusion criteria, sometimes we also even in particular places, it's overly restrictive. Too many 15, 20 exclusion criteria, there's hardly anybody left. And nobody justifies why they put those exclusion criteria. So a key barrier to low enrollment in clinical trials is too many exclusion criteria. So in one example, 80% of patients in a non-small cell cancer trial were excluded because they didn't fulfill inclusion or exclusion. And 86% of clinical trials failed to complete their recruitment. All of us find sample size when we do PG6. But if you world over, most clinical trials don't finish their samples. So that is a bit of a problem. So these data-driven algorithms combined with real-world data can potentially improve these aspects. So I'm saying that I'll give you the reasons why clinical trials are problems. So AI can screen people for potential eligibility. We can screen large numbers of people if we give the database who are potentially eligible. Then it will tell you among those potential eligible people, which people based on maybe this guy is alcohol user, he may not comply and stay the full length of the trial. Under that is the inclusion criteria. It can extract all those features from electronic health records and give you the data. We don't have to sit and collect those data from electronic health. And then most importantly, it will tell you that, okay, we can relax many of your exclusion criteria. If you relax these exclusion criteria, the number of potential patients goes up. If you have very strict exclusion criteria, we can't, our number of potential patients comes down. That's a big problem for our clinical trial. We can't find those rare patients who fulfill all inclusion and exclusion. So I'll tell you how we can relax those exclusion criteria. So I'm going to give an example of this Platinum Health database and tell you how they, in a clinical trial, they reduce exclusion criteria. It sounds a bit like science fiction, but it really is worth doing. So this is a particular web company, it's a company called Flatron, and it's a flexible approach to prospective and retrospective real-world evidence generation. So there's a companies available now to help you do your clinical trials using AI. So I'm just going to give an example of how they used it. I've always given the web link so that if you want the presentation later, you can always go and see how they are doing that. Okay. So the first thing is, this is people with lung cancer. So you take real world evidence. You have mountains of people with some lung cancer. That's the data set available with you. And you say that, okay, I need people above the age of 18 years of age. The AI will automatically within itself, it'll see that, oh, there is sex and there's a drug. And it will tell you what would have happened. Okay, arm A is drug A, this is B is arm B, or the control is this. So the AI is able to tell you what is drug A, I mean, you tell the AI this is drug A, this is drug B. Based on its this propensity score, we did what's propensity score. So it's using propensity score matching. You're not done anything, you're not done the trial at all. Using propensity score matching is saying what would have happened with drug A, what would have happened with drug B. And it gives you a survival curves. You didn't do a single thing. You're just sitting here and watching that. Then it will tell you, okay, if we put criteria, inclusion criteria 1, 2, and 3, we have 1,000 patients. And the hazard ratio potentially at the end will be 0.7. If we take criteria 2, I mean, we reduce the number of exclusion criteria, we can potentially recruit 3,000 patients out of the potential number of patients we have, but the hazard ratio may change to 0.8. In the sense you're playing God, but it's like telling you, okay, just slight reduction in slight relaxation of exclusion criteria, the potential number of patients will become so high, but you may suffer, your hazard ratio may change a bit. So now we are combining this on this trial pathfinder. So there's something called shapely values, which I'll tell you about in the next slide. And it will tell you how this actually is done in clinical trials. So you got the general idea. You can sit here with the data and see what's going to happen. And then if I tweak the inclusion like this, what will happen? If I tweak it like this, what's going to happen? Okay, so let's have a look. Now, looks like a complicated picture, but I'll just go through that. On this are different cancer trials, checkmate trial, keynote trial, every trial has got a fancy word. And on this side are inclusion criteria. For example, ECOG is the European Cancer Oncology Group criteria, right? And the top graph is hazard ratio. This square is hazard ratio. The bottom right one is sample size, or the number of potential patients available for recruitment. So we'll find that all the squares, this shapely square, this blue means this will potentially reduce the hazard ratio. So if you include people with ECOG status, hazard ratio may potentially decrease. White means there won't be any change. Red means potentially hazard ratio will increase. So for each of these trials, it's telling you what would have happened if you had put this inclusion criteria, what would have happened if you didn't put this inclusion criteria. And similarly, it's telling you now that the number of patients would have reduced. Suppose you had put ECOG status in this OAK trial, the number of patients potential would have come down significantly. White means nothing would have happened. Light green, white is unaffected, so that you can look at the colors and decide, oh, so from this it's telling you, okay, this is what would potentially happen in your future trial. If you put this inclusion criteria, if you don't have inclusion criteria, which of those will affect the hazard ratio, which of those will affect your potential number of included patients. So this is how, using the shapely values, you can do this. That's shapely values. Okay, so just look at one. So I told you there are two things: hazard ratio. What will be the potential if I do this inclusion criteria? What will happen to hazard ratio? If I do this inclusion criteria, what will happen to some potential number of patients eligible? So let's just look at histology. If I put non-squamous, if I include non-squamous, there's hardly any change in hazard ratio. The hazard ratio looks almost the same. In the keynote trial, it's hardly different. In this checkmate trial, you can see that the hazard ratio is hardly changing. But the same thing, if I include that decrease in the number of potentially eligible patients, the number of eligible patients in all those same trials decreases. So then, okay, maybe I can just exclude that and then I get more patients without sacrificing any hazard ratio. Similarly, ECOG, it will tell you that, oh, hazard ratio red means there is a significant change in hazard ratio and also sample size. So we have to now consider that whether we want to use these or not use these and what's the benefit. So this is a data-driven approach. So we can get a smaller subset from the original 10,000. But it will increase the number of potentially eligible patients from 1,500 to 3,200. A small change in the inclusion criteria. Overall, we know that probably our survival hazard ratio is going to change a little bit. But more women and older people are included by the strategy. So the generalizability of our study goes up. And we can say that we can even relax criteria. They said that, instead of hemoglobin 10, there's no difference if I put hemoglobin 8. That is the potential number of patients goes up without any penalty to anybody. So this is the diversity becomes more. We can take more people of different ethnic backgrounds. So that's all I wanted to say today about a little bit about ethics and AI, and a small component about how inclusion criteria can change using AI. So we switch here now to generalized pairwise outcomes. They are taken with the earlier ones. Any questions on this today?